ได้สไลด์กันหรือยังตะกี้ผมส่งให้เพื่อนไปแล้ว
เรียบร้อยแล้วค่ะอาจารย์แจกจ่ายแล้วค่ะ
งั้นเดี๋ยวเราเริ่มกันเลยดีกว่าโทษทีตะกี้ลิงก์มันผิด Okay, in this afternoon session, I will talk about the atrioventricular reentrant tachycardia and the accessory pathway, or the AVRT. I have talked about it in some prospect in the last lecture, but we will dig deep into the details about the accessory pathway and this tachycardia. So this is the outline of this afternoon lecture. Um, I will talk about the history of the pathway, types of accessory pathway and pre-excitation syndrome, the management of the pre-excitation syndrome, how you can localize the accessory pathway. This one is important because if you want to do the ablation, you have to identify which location is in the heart where the pathway is, because if you identify it in the wrong location, you might go to the wrong chamber of the heart. And how to diagnose it with the electrophysiologic features. And the last one, we will talk about the catheter ablation for the accessory pathway. So let's start with the history. Um, the first person, Mr. Wilhelm His Jr., found that there is only single bundle connected between the atrium and the ventricle of the heart, which we name that connection after his surname, the His bundle. And after that, in the year 1906, Mr. Sumao Tawara discovered that this bundle originates from a complicated network of small muscle fibers. And to the 1913, Stanley Kent had discovered what he described a human heart with an extra connection between the right atrium and right ventricle. So this accessory pathway was called a bundle of Kent. If anyone have heard about it before, uh, sometimes we used to call accessory pathway a bundle of Kent. And after that, in the year 1930, they are reported from uh, these three doctors, Dr. Wolf and Dr. Parkinson and Dr. White, about the syndrome, which there mostly occurs in young men and women with a manifest of ECG with short PR interval, wide QRS complexes, and there is a paroxysmal tachycardia happening in those young uh, men and women. We call this syndrome a Wolff-Parkinson-White syndrome, which is one of the accessory pathway abnormality in the patient's heart. So, what are the types of accessory pathways and pre-excitation syndrome? There are many types of accessory pathway. We call the name of the pathway have been named after the originate of the pathway and where the pathway leads to. There is AV pathway. Usually we have encountered this type of pathway the uh most almost all the time. The AV pathway is what Dr. Wolf Parkinson White have described in his series of patients. Another type of pathway is atriovascular pathway, which connect between the atrium to the fascicle to the left fascicle. left or right fascicle. The third one is nodoventricular pathway. It's the connection between the AV node into the ventricular pathway. The fourth one is fascioventricular pathway, which connect between the fascicle into the ventricle. And the last one, the atrial His pathway, which connect between the atrium into the His bundle. Not all of this could lead to tachycardia, but it could manifest in a unique physiological manifestation when we do an EP or electrical physiologic study. So there are many types of fibers in which were named after the doctor who discovered it. These fibers are subset of the last slide that is the subset of the types of accessory pathway, like James fiber. James fiber was used to call an atrial Hessian bypass tract. This James fiber was discovered by Dr. James. It manifests by a short PR, but there is no delta wave. Ken bundle is the bundle which were described in Wolff Parkinson White syndrome, which is an atrioventricular bypass accessory pathway. Almaham fiber or a decremental anterogate conduction pathway is was described and it is a subset of nodoventricular, nodovascular, fasciculoventricular, and atriovascular bypass. There are um, there are other accessory pathways that were described, like Long-Ganon-Levy and Clerk-Levy-Christesco. You don't have to remember this all because nowadays we didn't use the name of doctors to describe this bypass tract. We just use where it's originate and where it's in to describe this type of accessory pathway. And by far the most common type is still atrioventricular or the kin bundle. This one is the most important one that you should know about and you should know about its electrophysiologic uh, property. So how can the pre-excitation occur in the 12 leads ECG? The pre-excitation can occur during normal sinus rhythm of the patients. It happens because when there is two conduction between the atrium and ventricle. The first conduction is the normal one, which people have is the AV nodal conduction. Assuming this is the sinus and it keep coming down from the atrium through the AV node into the his and to the ventricle. And there is another pathway that could be conducted between the atrium through the bypass tract into the ventricle. So there is a manifestation on the ECG which would show very short PR interval because there is some of the electric signal bypassing the AV node using the bypass tract, bypassing the AV node into the ventricle. So the PR is very short because the duration of the conduction is faster than the normal conduction of AV node. And also the QRS complex is wider than people who don't have the accessory pathway because when you have accessory pathway, some signal have to detour and have to activate more myocardium in the heart in order to reach the action potential. So the QRS complex is the sum up between the signal of the conduction through the AV node and the conduction through the accessory pathway. So it will show in the 12-lead surface ECG that the PR is very short due to the conduction velocity that is faster than normal people, and the QRS that is very wide due to the more activation of myocardium using both normal pathway and the accessory pathway. In some people, the accessory pathway could not conduct anterograde. They could not conduct down from the atrium to the ventricle. So we could not see the difference between uh, the pre-excitation and the normal ECG. The ECG would likely be the same as in normal people, but this type of patient could conduct could experience a tachycardia because some pathway could not conduct anterogradely but still could conduct retrogradely. So when the patients in normal sinus rhythm, you won't see any manifestation on 12-lead ECG, but patients still could experience a narrow complex tachycardia. Okay, what is the prevalence of it? It is around 0.15 to 0.25 in general population. And if there is a first degree relative of the affected patients, if they have mother or father who have this syndrome, the prevalence was higher. 40% is intermittent. It means that 40% can experience tachycardia intermittently. 30% will disappear at 5 years. So it is age-related degeneration. This means that you could experience this pre-excitation ECG pattern when you were young, and after that, the bypass tract was degenerate when you grown up, and you don't have to do anything with it because it degenerated and could not conduct the electricity down. And 10% would develop arrhythmic events. 5% potential life-threatening arrhythmia. Um, you have to remember that this syndrome could lead to a life-threatening arrhythmia, such as atrial fibrillation with bypass tract. This is one of the most dangerous arrhythmia. Okay, so uh, as I have mentioned before, this is the picture of patient who have a pre-excitation. The patient is in a normal sinus rhythm. Uh, the signal come through the AV node, the normal conduction, and also come through the accessory pathway. It would result in a short PR, a wide QRS, and also the important one, the delta wave. The delta wave, if we see the delta wave in 12 leads ECG, it tells us that this patient has some pre-excitation that could conduct anterogradely during normal sinus rhythm. So this is the ECG, which has some pre-excitation. You could see from, you see from the leads 2 here. The patient has a very short PR interval, and the delta wave is the slur of QRS complex, the slur of R wave. The leads that you could see it's quite clear is in the V2. You see that the QRS complex is slow. And in this patient, the QRS was quite wide. It is around 120 milliseconds. Okay, so this is uh, the ventricular pre-excitations. Um, when the patient has an when the patient is in a normal sinus rhythm, some of the signals comes down into the AV node, and some goes down into the accessory pathway. They have to share uh, the signal together. But if you could increase the delay in AV nodal time, or you could block the AV node. If you block this AV node, the signal would come down into most of the signal would go down into to the ventricle via the accessory pathway. This could increase the pre-excitation. You could see more prominent delta wave, and you could see a wider QRS complex. So if you do anything to delay the AV nodal conduction, there would be more and more pre-excitation for you to see. And if you increase the conduction uh, through the AV nodes, such as when you put the patient into exercise, and if the conduction through the AV node increase, you will see less pre-excitation. And again, this is what I have talked about. This one, uh, the AV node still conduct, so you could see a minimal pre-excitation, the first one. And the second one, you delay the AV node conduction velocity, so more signal came through the accessory pathway. And you could see the delta wave more prominent and QRS are wider. And now you block the AV node, and you could see that the delta wave is the most prominent and QRS is the widest. This is the ECG of Lon-Ganon-Levin syndrome, which is one type of the pre-excitation. This ECG has a very short PR interval, but you could not see any delta wave. This is the typical ECG for Lon-Ganon-Levin syndrome. A short delta wave, a short PR interval without a delta wave. So, what is the electrophysiologic characteristic of accessory pathway? The first one is when the patient is in normal sinus rhythm. So you could see a short PR interval and a delta wave. The second one is the autonomic AVRT. This is a narrow complex tachycardia, which you use. If you can remember from the last session, we talked about the re-entry circuit. Um, I want you to imagine that this accessory pathway is similar to the re-entry circuit in the AV node, but it is a large re-entry circuit which involves both atrium and ventricle. The AV node conduction and normal conduction is a slow pathway. The accessory pathway is a fast pathway. So in orthodromic AVRT, the anterograde conduction would come from the AV node and normal conduction of the heart, and the retrograde pathway using the bypass tach and causing the tachycardia. This would result in anaerobic QRS complex tachycardia. Another electrophysiologic character of the accessory pathway is antidromic tachycardia. The antidromic tachycardia used the accessory pathway as an uh, anterograde limb of the reentry circuit and used the retrograde limb of the AV node and the bundle of his as an anterograde limbs. And this causing a Y QRS complex. Uh, this caused a Y QRS complex because the signal have to detour around around the atrium and ventricle to reach the accessory pathway and come up through the slow pathway of AV nodal. And so it result in a wide complex tachycardia. This is the example of an orthodromic AVRT, which is a narrow regular complex tachycardia. As I have teach you before, you have to identify the P wave of the ECG. Here is the P wave here, and is here. And after you identify the P wave during the narrow complex tachycardia, you have to see which the ratio of A to V, or the atrial rate to the ventricular rate. In this patient, it is 1-to-1 ratio. When it is 1-to-1 ratio, after that you have to see if it is long RP tachycardia or short RP tachycardia. In this patient, you measure from the R wave to the initial of P wave, and surely it is a short RP tachycardia. After that, you have to see if what's duration of the RP. In this patient, it is likely that the RP is longer than 70 milliseconds. So AVRT is the first differential diagnosis of this patient. But again, I have to say that you have to do the electrophysiology to confirm it. Okay, how to manage the pre-excitation syndrome. This is what I have already talked about. I want you all to remember this, and it is very useful when you encounter the real patient. So again, this is a narrow QRS complex tachycardia. Um, can anyone read this ECG for me? Anyone want to read it step by step?
Oh, it's narrow QRS.
Okay.
And there is P wave.
Okay, you see the P wave. And what is the ratio of P wave to QRS?
1-to-1.
Okay, it's 1-to-1. And what about what is the RP and PR interval? Long or short RP?
RP is shorter.
Okay, it's short RP. So you think it's less than 70 milliseconds or longer than 70 milliseconds?
I think it is longer.
You think it's longer? Um, okay. Okay. I think this one is shorter because I think this is P wave, but it's okay. Um, Sometimes in the real clinical settings we identify the wrong P wave because it is not so visibly clear in the ECG. But if you can answer that it's a short RP, it's fine because we have to do the EP study to confirm the type. Okay. Um, this one is AVNRT because I think it's a very short RP, less than 70 milliseconds. Comparing to this one P wave is here. P wave is a bit longer than that one. This one the RP interval is more than 70 milliseconds. So this one is the first diagnosis is the AVRT, the orthodromic AVRT. And here is again an orthodromic AVRT. You see that the P wave is not clearly visible from this one. So I just want you to tell you that it is not sometimes you cannot get the definite diagnosis from the ECG. Okay, so how do we manage? There are some patient with pre-excitation during the normal synapse rhythm that could initiate the tachycardia. This group of patients surely have to be treated. But there's some people who have a manifest of pre-excitation on the ECG, but they never experienced any tachycardia before. Do we have to manage it? I'm going to talk about it now. There is some risk of cardiac arrest or ventricular fibrillation around 0.24% per year in patients who is asymptomatic pre-excitation. There's a slight risk of cardiac arrest, but very low, but there's still some risk. So um, we have to select the patient carefully to treat them. First of all, we have to see if the patient has a high-risk occupation or a competitive athlete. A high-risk occupation was defined by um, an occupation that have a responsibility to many other people's lives, such as a pilot, um, a bus driver, or a, a scuba a scuba diving patients. And also in a competitive athletes, this could be harm when the patient has a competitive sport and can lead to the VFib. If the patient has these uh, occupations, we would go for an EPS or electrophysiologic study to stratify the risk to see if the accessory pathway it has any high risk feature or not. If the pathway has a high risk feature, we would go on to eliminate the pathway. What is the high risk feature? The high risk feature is in the left side here. The Spurry. Spurry is the shortest pre-excitation RR interval, less than 250 milliseconds. The action potential effective refractory period, less than 250 milliseconds. There's multiple accessory pathway, or you could induce an arrhythmia inside the EPS, even if there's no arrhythmia in that patient's life. But when you put the catheter in, it could induce the arrhythmia using the accessory pathway. These are the high risk properties. You don't have to worry about this now. I will talk about it later. If there is one of these high-risk property, we would go on to eliminate the accessory pathway. If there is no high-risk feature, you could follow up. You could just follow up the patients, or you could ablate the accessory pathway, but you have to discuss with the patient about the risk of ablation first. So if the patient is not an high-risk occupation here, you have two choices. First of all, you can talk to a patient and go through the EPS risk stratification. And if it is some high risk feature, you could go on and ablate it. Or you can do a non-invasive risk stratification. For example, an exercise stress test to see if the delta wave is disappearing during the exercise or not. And if it is a low risk feature of the non-invasive test, we would go on to follow up the patients, or we would discuss with the patient, and if they could handle the risk of ablation, we may uh, bring them to do the catheter ablation. So not all patients with asymptomatic pre-excitation would have to be treated. The low risk feature here of the non-invasive test is the loss of pre-excitation during EST. The loss of pre-excitation means that the PR not is the PR go back to the normal, not a short PR, and the delta wave it disappear. Or the loss of pre-excitation during the following the infusion of procainamide, propafenone, and disopyramide. These are antiarrhythmic drugs. So this is a patient with when the heart rate is around 117 beats per minute. Here, there is a pre-excitation. You can see it clearly. There is a short PR interval, and there is also a delta wave. After the heart rate increased during the exercise, the QRS become narrower. Delta wave has gone, and PR interval was longer. This means that during the exercise, the pre-excitation has disappeared. So this one you can stratify into a low risk group after we have done a non-invasive test. Yeah, you can say these are low risk phages. And this one is, I described it before. It is one of the most malignant arrhythmia, and atrial fibrillation with ventricular pre-excitation. This is when there is an atrial fibrillation occurring in the patient atrium, and you know that the AFib rate is very fast, very fast, and usually when the patient don't have pre-excitation, the AV node, which has decremental property, could slow down the rate of AFib by preventing all of the signals, some of the signals from being transferred to the ventricle. But when the patient has pre-excitation, has the second accessory pathway, there are a lots of signal from atrial fibrillation that could conduct through the accessory pathway, and this would result in a very fast heart rate, which could lead to ventricular fibrillation and cardiac arrest. The ECG defines by a Y QRS complex, which you can see that there is a delta wave in the QRS complex. It is very fast, and also here's the delta wave, and also it is irregular in rates as just as the AFib in a norm without accessory pathway. When you encounter this, you should treat the AF immediately. So this is the tracing of patients with AFib with pre-excitation. You could see that in the 12 lead in the surface ECG, the QRS is quite wide. There is some delta wave, and it is irregular. You put the catheter in, you put the atrium catheter, you put the CS catheter in here, CS catheter, and you put the RV catheter. You see that the signal of atrium is irregular and quite chaotic. So we can diagnose this from the surface ECG. We could diagnose it is an atrial fib with pre-excitation. And when you put the catheter in and you see the chaotic of the atrial signal, you could confirm that this one is an AFib with pre-excitation. So what do we do if the patient is in the pre-excited AF? First of all, we have to evaluate if the hemodynamic of the patient is stable or not. Is the patient is in shock or heart failure? If the patient has those hemodynamic instability, um, you have to go on to do the synchronized cardioversion immediately to turn the sinus rhythm. But if the patient is not, uh, the patient is stable, you could use the medication to eliminate the AFib, but you should avoid AV nodal blocking agent because, as I have said before, if you block the AV node, all of the signals would go down into the accessory pathway, which would cause the patient's heart to beat very, very fast and would likely to result in ventricular fibrillation. So again, this is the slide I have mentioned before. So we would see what is the difference between autodromic AVRT and antidromic AVRT. I will speak again. The autodromic AVRT, this one is the accessory pathway. This one is the normal AV node. In autodromic AVRT, we use the slow pathway, which is the normal AV nodal conduction as the anterograde limbs. And the retrograde limbs is the fast pathway of accessory pathway. And this would result in a narrow complex QRS. What about the antidromic AVRT? The antidromic AVRT use the fast pathway, the accessory pathway as the anterograde limbs here, and use the AV node as a retrograde limbs here. This would result in a wide complex tachycardia because if you can see that this limb would activate more myocardial cells than using the anterograde in the AV node region. This is the ECG of antidromic AVRT. You can see that it is a wide complex tachycardia with a regular QRS interval. So the antidromic AVRT, first of all, you have to identify that it is a regular wide complex tachycardia. And you have to see that it is positive QRS in leads V4 to V6, and the atrium to ventricular ratio have to be 1:1. If you see the wide complex QRS with an atrial to ventricle ratio more or less than 1:1 or dissociation, you could not diagnose it with antidromic AVRT. It must be other types of wide complex arrhythmia. So that is the manifest of pre-excitation syndrome and how it could run into a tachyarrhythmia. Now we are going to localize the accessory pathway, which location it is in the heart. To identify this location is important for the doctors to ablate the pathway. So this is I have to tell you that this localization is only effective in an atrioventricular bypass tract or the Wolff-Parkinson, right? Other types might not be used with this method of identifying the pathway. This is the anatomy of tricuspid and mitral valve. There's a region uh, in this anatomy, the left anterolateral, left lateral, left posterior, posteroseptal, right posterior, right lateral, and right anterior. These locations could be the locations of the accessory pathway. And there is two nomenclatures. There's two theory of the locations of the accessory pathway. The left one was a traditional nomenclatures. We call the accessory pathway using the traditional one, and the right one is the new or the proposed nomenclatures. We can call the location of the accessory pathway after this nomenclature. But usually in the clinical setting, we still use the traditional one to to describe the location of the accessory pathway. So the predefined retrograde AP localization around both AV node and annular rings. Okay. Uh, you can use the 12 leads ECG, the positive and negative of R wave and QRS complex to identify the locations of the accessory pathway. So there is a question if it is concealed during the sinus rhythm, can we identify the locations? The answer is no. You have to induce to you have to induce arrhythmia inside the EP lab, and you have to map the location of the accessory pathway during the tachycardia using 3D mappings in the EP lab. The patients with concealed accessory pathway, which mean that the accessory pathway could not conduct the signal down from the atrium, but still can conduct the signals from ventricle to atrium or the retrograde uh, uh, propagation, has 64% has left free wall accessory pathway. 31% have septal accessory pathway, and small amount of patients have a location of right free wall pathway. This is the T-wave subtraction of the retrograde P-wave during autonomic atricular during the AVRT. The first one is the number one is a sinus ST segment during sinus rhythm. The second one, this one is the ST segment during AVRT without the application of T-wave subtraction. And the third one is the ST segment after the application of T-wave subtraction. The true uh, retrograde the true retrograde P-wave polarity is positive in this one. You don't have to remember this. This one is just you use the you use the you mean that during the sinus the P wave was negative, right? And when there is when the patient is when there is a tachycardia, the patient's the ST segment of the T wave is isoelectric. So it means that uh, during the tachycardia, the retrograde P wave, which go up into the atrium, have to be positive because it is the sum up between the T wave in normal sinus rhythm and the retrograde P wave. So if we subtract it from the T wave in the normal sinus, surely the retrograde P wave should be positive in this lead. Anyone confused about this, but it is not clinical applicable in a real setting. Just want to tell you that you could use this subtraction to see if the P wave is positive or negative polarity. Okay, let's move on to the more important one. This one is when we use we can use the p-wave subtraction to identify the location of the accessory pathway. Okay, this one. Okay, we can use the retrograde p-wave to identify the accessory pathway, but it is not uh, a common clinical tools to use. These three slides, I just want you to know that we have this way of this method of identify the pathway, and this is the prevalence of the accessory pathway. The most common type of accessory pathway is left lateral pathway, consists of around 60% of all pathway. The second most common is the posteroseptal pathway, around 25, and the least common is the anteroseptal pathway, around 2% of the patients. So this is the location of the pathway, which I have talked before. If you divide it in new nomenclatures, you can see that the most common one is the left posterior pathway, but usually we use the traditional nomenclatures. So this one is the most important method to identify the localization for accessory pathway. It's called the Aruda criteria. For the step 1, there are 4 steps in using this pathway. Step 1, we look into lead 1 or V1 leads. Usually I use V1 first to see if the R to S ratio is more than 1 or not. If the R to S ratio is more than 1, or the QRS complex in lead 1 is isoelectric or negative, it should be left free wall accessory pathway. And after that, after we identify that it is a left free wall accessory pathway, we would see the QRS complex. We would go to see the delta wave in the AVF lead. If it is positive, it should be left lateral or left anterolateral bypass tract. If it is isoelectric or negative, it should be left posterior or left posterolateral. This is because I will draw. This is the mitral valve ring. This is the AVF leads, which is an inferior leads. If the signals come from the posterior part, this one is posterior, this one is anterior. If the signal come from the posterior part to the ECG, here is the surface ECG, the signal would go into the signal would go into would go out from the AVF into the surface ECG, which would result in a negative AVF. But if it is a lateral anterior accessory pathway, the signal would go come from outside and go into the AVF. So the AVF is going to be positive. And the step 2 is to look at the lead 2. If it is negative, the accessory pathway should be in the coronary sinus or in the middle cardiac vein. On step 3, you go back and look at the delta wave in lead V1. If it is, if the delta wave is isoelectric or the delta wave is negative, it should be a septal pathway. And after that, we use the AVF to classify further that it is anteroseptal, midseptal, or left posteroseptal, or right posteroseptal. And step 4, the remaining, all of which is not consist with the 3 steps before, would be in the right free wall. This is you have to remember this diagram to identify the accessory pathway. Sometimes I could not remember all the details. I still have to uh, look up into this diagram when I encounter some patients. And there are a lot of other uh, this is the summary of the Aruda criteria as the last slide have mentioned. Here is the example. For the step 1, you see that you look at the V1 first. The V1, the R to S ratio is more than 1. So this patient is likely to have left free wall pathway. After that, we go to look at the AVF here. The delta in the AVF is positive. So it is likely that the signal come from the anterior front into the AVF leads. It is likely to be left lateral or left anterior lateral. And this is the step 2. If the ECG is not consistent with step 1, you go to step 2 and you look at the lead 2. If the lead 2 is negative, the delta wave is negative, you could tell that the accessory pathway is in the choric sinus or in the middle cardiac vein. And if if the ECG is not consistent with step 1 and step 2, you would go to step 3. The step 3 here, look at V1, but look at the delta wave. If the delta wave is isoelectric or negative, in this one, I think maybe it's isoelectric here. The delta wave is isoelectric here. Not you are not seeing it clearly if it is positive. It's isoelectric, so it is a septal pathway, and after that you would go to see if the AVF in the delta wave in AVF is positive or negative, and you could identify the location of it. And this is the step 4, the remaining one, which is the right free wall of the bypass tract. You don't have to worry about this much because if you are new to the accessory pathway ECG, you should open the diagram or open some book and slowly identify it from the ECG. And if you have a patient who undergone an electrophysiologic study and ablation, you can match it with what you have read before and practice this a lot to get it accurate. This one is another method of identifying or localizing the accessory pathway. I will not speak into detail of this, but I just want you to know that there are a lot of proposed theory of identify the accessory pathway. Here is another theory. Okay, so we are going to move on into the electrophysiologic features. Anyone has any questions about the ECG previously have mentioned? You can ask me now. Okay, if nobody is asking, I would go on to the electrophysiologic feature of the accessory pathway. This part is the most important part for you. Okay, this is the same as we have mentioned before. The ventricular pacing to see how the retrograde atrial would be. The left one, just for the reminder, is the concentric atrial retrograde activation because the earliest atrium is in the His bundle and proximal CS region. And the second one is eccentric retrograde atrial activation because the earliest retrograde atrial activation occurs in the distal choroid sinus. This is to describe the concentric retrograde atrial activation and the eccentric retrograde atrial activation. Because when you have an accessory pathway, the accessory pathway could retrograde into the atria. So here, when you pace from here, the signal could go up both this direction and this direction. But as you know before, the accessory pathway do not have any decremental property. It could not slow down the signal. So the signal from which travel through the accessory pathway would likely to reach the atrium first, and this would result in the activation from the CS catheter, distal CS catheter first, because the distal CS catheter will be in here. This one is CS1 and 2, and CS proximal is in here. So the CS catheter 1 and 2 would be the earliest retrograde atrial activation. So it is would likely to result in an eccentric retrograde atrial activation. It is different from the concentric retrograde atrial activation because if it is occur in the concentric way, the signal would go up through the AV node and the normal bundle system. And that imagine that there is no accessory pathway here. The signal from pacing would go back up here. It would reach the His bundle region first, and then after that, it would reach the CS9 and 10 here before the CS1 and 2. So it would likely result in concentric retrograde atrial activation. This is the quiz. Uh, can anyone read this retrograde atrial activation for me? We are doing the ventricular pacing.
The earliest A is like at the His, so it would be concentric.
Okay. And what about this one? You see the
That one
difference?
is eccentric because the distal CS come first.
Okay. So can you tell me why it happens just like this?
No.
Okay. So you are sure that there is some accessory pathway in this patient because it appears that there is a eccentric retrograde atrial activation. And it happens because when you go back to this one, to this slide, there must be some block in the AV node. The first one, this one, the signal goes up to the through the His bundle and AV node to the atrium. But when you pace faster, you pace this beat faster, there is a block in the AV node because the last bit that goes back to atrium makes the AV nodal and the His bundle region into the refractory period. So the signal from pacing could not go up AV node. Instead, they go through the accessory pathway. So it shows that there is an eccentric atrial activation. So you can diagnose that there is a accessory pathway in this patient. You have to be careful that when sometimes if you pace not fast enough, it the retrograde atrial activation would still retrograde via the AV node. But when you pace faster and you make the AV node goes into a refractory period that could not conduct the signal retrogradely, the the atrial signal shift into the accessory pathway, and you could see that it should be an eccentric atrial activation. Okay, the change from eccentric to concentric atrial activation. Um, uh, okay, it's quite similar to what I have spoken in the last slide. The last slide is the change from concentric to eccentric because there's some block in the AV node, and then the signals travel through the accessory pathway. But the change from the eccentric to concentric is when there is something that makes the AV node uh, conduct better. For example, if you pace slower and the AV node could recover from the refractory period, and this would result in uh, using the pathway using the less pathway to conduct through the ventricle to atrium, and this would result in concentric atrial activation. Or if you have given a patient some kind of medication such as isoproterenol, which enhance the AV node conduction, this can cause the change of eccentric retrograde atrial activation into a concentric retrograde atrial activation also. Anyone has questions about this? Okay, if there's no question, I would go on to the next slide. This is a ventricular pacing, and you see that there is VA, VA, a ventricular pacing with a retrograde atrial conduction here. And the earliest retrograde atrial conduction is in the His bundle region. Okay, and when you pace here, it is still a concentric retrograde atrial activation. And after that, you pace faster with a shorter cycle length. You want to make the AV node into a refractory period. You are hoping to see that the retrograde atrial activation would shift from concentric to eccentric. But after you pace with a faster rate for a while, there is a block in an AV node. There's a V but no A. There's a block here, and there is no retrograde atrial activation at all. So assuming that there is only one pathway connecting the atrium and ventricle in this patient, the orthotomic AVRT is unlikely to be in this patient because you block the AV node, but and there is no connection between the A and V at all. The signal cannot travel into the ventricle. Okay, anyone has questions about this?
Can you explain it again?
Okay, um, here is the with you do the ventricular pacing, and it gives you a concentric retrograde atrial activation. The concentric retrograde atrial activation is likely to retrograde from the ventricle to the his and AV node and back to the atrium. This one is okay. And you pace faster here with the less cycling because you want the AV node and the his region to be blocked or to be in the refractory period. And you hope to see that if the AV node is blocked, the retrograde atrial activation would change to eccentric pattern, because if the AV node is blocked, then the signal from ventricular pacing would go to another pathway, go to the accessory pathway and go back to the atrium. You hope to see that. But in this patient, when you pace faster and the AV nodal is blocked, the signal from ventricle cannot reach the A at all. No A here. The signal cannot reach it at all. So we assume that there is only one connection between the atrium and ventricle, which is the AV node and his bundle. There is no accessory pathway in this patient. So we could assume that the tachycardia that happened in this patient is unlikely to be autodromic AVRT. Is that okay?
Yes, Ka, it's very clear.
Okay. This one, the show VA block and no change in the pattern of accessory pathway. This one also, this one is similar to that one. You can see that here is the ventricular pacing. Here is the ventricular electrogram, and here from the A is the atrial electrogram. You could see that this is the V and A here has no relationship between each other. This is called the VA or the AV dissociation. What does this mean? The VA dissociation between it means that there is no connection at all between the ventricular and the atrium. So it is not possible to have an AV dissociation and the accessory pathway, because if there is some accessory pathway, there must be some connection, even if the AV node was blocked. So in this patient, there is no connection at all. It is a complete AV block. If the tachycardia occurs in this patient, it shouldn't be an autodromic AVRT. Okay, this one show the atrial pacing. This is when you pace from the atrium here. You pace from the atrium here with the rate cycling of 360. And you see that if you pace A, it would go to his, and it would go down to RV. You pace A here, his, and RV. This is the pacing cycling of 360. And when you pace faster here, you pace faster here, there's A go to his and V. A his V, and you see that the his and V interval is shorter and shorter and shorter here. The HV interval is shorter and the his signal goes inside into the QRS complex in the surface ECG. But you can see in the surface that when you pace faster and faster, there is a block here in 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 the AV node. This is also called the AV dissociation between AV node and ventricular. So it is unlikely to be accessory pathway. I will explain it again. I think it is quite confusing here. You have to look. You look at the ECG first. Okay. Here is when you pace at the rate of 360 milliseconds. You see that there is an A his V in every beat here. And when you pace faster, the signal from A to H here is likely to be delayed because like if you can recall, there is a decremental property in the AV node, which is which occurs when you pace faster, and the AV node goes into a refractory period. The AH interval, which is the timing from the atrium to conduct through the AV node to his, is slower, and and the the and it would result in the AV block if you pace fast enough to to get all the AV node into the refractory period. And if the AV block occurs and you see the dissociation between the A and V, that's mean there's no connection between A and V because AV nodal was blocked already. We can assume that there is no another accessory pathway connecting between atrium and ventricle. So the accessory pathway is unlikely to be in this patient. Do you have any questions about this? Okay, if there is no question, the keyword is when there is AV block occur and there's dissociation between A and V, which means there's no connection between atrium and ventricle. The patient is unlikely to have accessory pathway. This is a keyword. Okay, what about this one? This one, you pace atrium from here, from the atrium, from this here. You can see that there is AHV in the his signal. This is the pace beat, the same as the previous beat. And then you pace faster here. You pace atrium here faster to get the AV node into the refractory period. And you could see that it is still, there is some conduction down to the ventricle here. And his signal come after the ventricular signal. You can assume that there is an anterograde accessory pathway in here. I will explain why. So this is the patient heart. This is the patient heart here, and AV node is here. Here is the his. Okay, and here is the V. And here is the accessory pathway. When you pace here at the slow rate, the signal would go through here down to V and also go down the accessory pathway. But when you paste in the right atrium, it is closer to the AV node. So most of the signal would go down through the AV node, which would result in these two beats. And when you paste faster, this one. You paste faster, the AV nodes was still in refractory period from the previous beats. So it could not go down here. The signal would go down, all of the signal would go down into the accessory pathway and reach the ventricle first. And after that, the signal would go up here into the his. So you will see that the his will come after the ventricle or with the same time as the ventricle. This is called a negative HV interval because usually the H have to come before V, but in a fully pre-excited beat, the his come after V. We call it a negative HV. You clear about this, right? Okay, if there's no question, go on. So how can it initiate the tachycardia? If you could remember the re-entry mechanism, which would consist of slow pathway and fast pathway. The slow pathway in these patients of orthodromic AVRT is the AV nodal and his pathway. The fast pathway is the retrograde limbs is the accessory pathway. So when the patient is in normal state, the signal would go into both pathway and signal in the and would result in a pre-excitation syndrome with a normal sinus rhythm. But when there is some trigger, which is PAC or the ectopic beats or the PVC. The premature beats comes before the sinus rhythm and come right after the previous beat. So there is still some blockage or refractory period of the fast pathway. The PAC would travel along into the slow pathway, which is the AV node. And after the traveling time have come to around this area, the refractory period of fast pathway have already recovered and the signal would go up into the accessory pathway of fast pathway and run as a tachycardia. So this is the initiation of the AV nodal reentrant tachycardia. This one is the pacing from this is the pacing from the atrium, and this result in a HV beat, which is this beat, and this beat is pre-excite because the signal can go into both AV node and accessory pathway. This one is the PAC. The PAC cannot travel down the accessory pathway because the accessory pathway is a fast pathway which has a longer refractory period. The PAC would travel down into the AV node and his region. You can see that his bundle come before the ventricular, and after that, the signals has the fast pathway or the accessory pathway have already recovered from the refractory period. So the signal from ventricle went up back to the atrium signal through the accessory pathway, and then it goes down again into the his region and to the ventricle and go up via the fast pathway again. And this would run into a re-entry tachycardia. So after we initiate the tachycardia, it is similar to the last session. We have initiated the narrow complex QRS tachycardia. The next thing we have to do, we have to look for is the pattern of a retrograde atrial activation. Can anyone tell me what is this pattern of retrograde atrial activation?
Eccentric.
Okay, it is eccentric. So in this one is narrow complex regular tachycardia, which is an eccentric retrograde atrial activation. So we can conclude already that this one is the orthodomic AVRT because it is eccentric retrograde atrial activation. And we can tell that it is likely to be left lateral accessory pathway because the earliest activation is at CS1 and 2. And this one is also a, a narrow complex tachycardia, but it is a concentric retrograde atrial activation. Also, like the last slide, this one, the VA time is quite long. It's a short VA time, but it is still longer than 70 milliseconds. So the differential diagnosis could be a typical AVNRT, autonomic AVRT, or AT with first degree AV block. So the step 2 diagnosis, the SVT is the same as I have mentioned before. You have to do the entrainment by the ventricular pacing tachycardia to see when you stop pacing, how would this tachycardia respond? It is VAAV or VA, and we would have to see if it is a long or short post-pacing interval. And the second one is to perform a PVC during his refractory period. And the last one is to see if it is what effect has it with the bundle branch block on the tachycardia cycle length and the VA interval. This is the same as the last lecture that if we entrain or if we pace from the apex, the RV apex is closer to the AVRT circuit than the AVNRT. So the post-pacing interval would be shorter in the AVRT. So you just have to remember this, that the post-pacing interval minus tachycardia cycle length in AVRT is less than 150 milliseconds because the RV apex pacing is closer to the circuit. And the post-pacing interval minus tachycardia cycle length in AVNRT is longer than 150 milliseconds because it is further away from the AVNRT circuit. And for the PVC during his refractory period, if it is in his refractory period, if it's an AT or AVNRT, you put the PVC in, it could not go back into the atrium because there's only one pathway connecting between the PVC and the atrium, and it is still in the refractory period. So it would not reset or it would not has any effect on the atrial signal of the tachycardia. But if there is a bypass track connecting between the ventricle and to the atrium. If the His and AV node still in the refractory, you put the PVC in, it would go up into the accessory pathway, and it would reset the tachycardia and would result in the advancement, the termination of tachycardia, or the delay of the atrial signal. I think I have mentioned this already. Here, I will talk about it again, that this one is the PVC during tachycardia, during the His refractory period. Here's the PVC you throw in. And you can see that the A to A ratio here is longer than the A to A here, because this A has the effect of the PVC. PVC can go up and activate the A, then it advances the AA to shorter than the previous beat. So this one patients has an accessory pathway. And again, the effect of bundle branch block, the Kummel side that I have previously talked about. If there is an ipsilateral bundle branch block, it means that during the autonomic AVRT, the patient used this both of the bundle branch to activate the re-entry circuit. But if there is some block here, this is the left bundle branch block, the signal would detour into the right bundle and goes back up to the atrial and up to the accessory pathway to the atrial. So if there is an ipsilateral bundle branch block that result in a different of the VA interval, you could tell that there is a accessory pathway in the patient. This example, there is a bundle branch block here in this ECG. Here, there's a bundle branch block here. You can see that. And this one during the tachycardia, the bundle branch block disappear. But the ventricular and atrial time and the RR, the cycle length of the tachycardia is still the same. There is no effect of bundle branch block during tachycardia. So this tachycardia, you cannot conclude that it is an accessory pathway or it is an AVRT. It is unlikely to be AVRT because when the bundle branch block occurs, there is no effect on the tachycardia. Different from this slide, you can see that there is a left bundle branch block here during the tachycardia. The VA interval is 120 milliseconds. The RR interval is 325 milliseconds. And after the bundle branch block disappear, the VA is shorter. It's because that when the bundle branch block occurs, there is some signal that have to be detour into another bundle branch and go back up to the accessory pathway. So the VA time and the RR interval is longer. And after the bundle branch block disappear, the VA time come back to shorter and the RR interval is shorter. This is the Kummel side. You can say that there is an ipsilateral bundle branch block in this patient. It means that if you see the left bundle branch block here, there should be a left accessory pathway in the patient. If the bundle branch block is right bundle branch block, and there is a Kummel sign like this, you could say that the bundle branch block should be on the right as the same side of the bundle branch block. Okay, so uh, we have discussed this before, and this is one of the important signs. And this is another method of pacing to identify the pre-excitation location. The left one is when you pace from the right atrium. You pace from the right atrium, and the signals goes down into the AV node. And also the signals try to goes down through the accessory pathway, but it could not reach the ventricle because the signal from the AV node go back up to collide it with it. You could not see from the ECG that there is a pre-excitation, or you could only see a small amount of pre-excitation. If you want to see more pre-excitation, you have to relocate the catheter to the nearer side of the accessory pathway. So you relocate the pacing from right atrial pacing to the CS. When you relocate it to the CS, it is nearer to the accessory pathway, so the signal would go down via the accessory pathway more, and this would result in more pre-excitation on the surface ECG. This is called the differential atrial pacing to see the pre-excitation more clearly. Here is when you have a right atrial pacing. This is the atrium. You see that you pace here, and the PR is quite long here, and you see that there's some slight pre-excitation, and the signal reached the ventricle. But when you pace from the choric sinus, you pace here, the PR is shortened, and some pre-excitation here. The delta wave is more prominent. And also another one, if you can observe from this one is A, and this one is his is here. But this one A, and you cannot identify his is blend with the ventricle. So if you pace from a side that is close to the accessory pathway, it would give you more pre-excitation. Another method that you could use to identify the accessory pathway is the differential ventricular pacing. The differential ventricular pacing is when you pace from a different side in the ventricle. You pace from the RV apex versus pacing from the base of apex. You pace from here versus here. And you pace from the RV apex within the accessory pathway. How could it help? When you pace from the apex here, if there is no accessory pathway, if there is only one pathway, there's no accessory pathway, the VA time would be here up to here. But if you paste from the base here, and there is no accessory pathway, the signal have to go down to the apex and go up to the atrium. So the VA time, the V and to A time from the base have to be longer. VA time of the base have to be longer than the VA time of the apex. But if there is accessory pathway. You pace from here, from the apex, and this is the VA time when the signal go up to atrium, compared to pacing from the base. And the VA time, the signal will get through the accessory pathway here. The RV apex VA time would be shorter or equal to the RV apex VA time. Okay, anyone has any question about this?
อธิบายอันสุดท้ายใหม่อีกรอบได้ไหมคะอาจารย์
Okay. The last one is when you have an accessory pathway here, which means that the signal could conduct up to here. When you pace from the apex here, right? The VA time would be here up to here. Would be X signal. And if you pace from the base, is pace here. Instead of going back to the apex and up to the AV node, the signal would go up directly via the accessory pathway here. So the RV apex VA time would be shorter or equal to the RV apex VA time. It is inverse than comparing to the patients who don't have the accessory pathway. Okay, is it clear?
yes
Okay. So this is the example. Here is when you pace from the RV apex. The S1 to A, the VA is 140. And here is when you pace from the RV base. The VA time is shorter. So in this patient, there must be some accessory pathway connecting between the area of RV base to the atrium. So I think that there is some accessory pathway in this patient. Another method of identifying a pathway is to do a para-Hessian pacing. So what is a para-Hessian pacing? Usually when you pace there with you I want you to see this two photo first. The first one is you see this, the pacing size is larger than this one. This means that the larger one is you put a high output into the patient heart. The smaller one is when you put a low output into the patient heart. When you put the high output into the patient's heart, the signal or the electrical signal would penetrate into the his, and it would go up back to the atrium and go down along the conduction system pathway. But if you put the small or the low output of the heart, the signal have to travel inside the myocardium to the apex of the heart here before it could go up back the conduction system to reach the AV node and his. This is the normal phenomenon of patient heart. If you put a high output enough to capture his, the signal would directly conducted from this area up into the AV node and atrium. But if you do not put the output high enough, it will have to travel along the myocardium, down into the end of the conduction system, and go back up into AV node. But in the patient with an septal pathway, you you put the high, this is the pathway here. You put the high output in, or you put the low output in to the patient. This would not result in the different property, because you put the you put the electrical signal in here. Even if it is a low output, it could use the bypass track and go up to the atrium. Even if you use the higher output, it still can go up into the atrium via the accessory pathway. So what is the difference between this one? In the normal heart without accessory pathway, if you put the high output in and the electrical signal directly capture the heat and go up to the atrium, this would result in a shorter VA time comparing to when you put the low output in the patients with normal heart. A high output will result in a shorter VA time than the low output in the normal heart without accessory pathway. But in the patient with a septal accessory pathway, there is no difference between the VA time when you put the high or low output, because you still can use the accessory pathway here to uh, reach back to the atrium of the patient. So the VA time would be equal. So this is the example. This is the example of the high and low output in the parahesian pacing location. You see that here with this one, you see that the QRS complex is quite different, because this is a low output beats. It captures myocardium more. The high output only capture with the his region. You see that if you use the low output or the high output, there is no difference or only slight difference between the VA time of the high and low output. The VA time is not prolonged more than 50 milliseconds. So this patient is likely to have an accessory pathway. Uh, this one is clear or not, or you have any question about this one? Okay, so let's move on. So those are the electrophysiologic properties and the manual to use to differential diagnosis between AVRT and AVNRT, or used to differential diagnosis that if there any accessory pathway in the patient or not. Then if we have already confirmed that patients has an accessory pathway, we would go on to the ablation or to the treatment, which is the definite diagnosis, a definite treatment of the accessory pathway. The site where we want to do the ablation is the site where there is a accessory pathway potential. Here, you can see that there is an accessory pathway potential, and the signal in the distal ablation is faster than the surface ECG, minus 20 milliseconds. This is the appropriate site for the ablation. Two things that we would like to see. First, the accessory pathway potential, but this might not be seen in every patient. And the second one is that the signal in the ablation, the distal ablation catheter, is faster than the surface ECG. This means that the ablation catheter is near the accessory pathway, is nearer the accessory pathway than the surface ECG. And also this one, there is a accessory pathway potential here. And the signals is faster than in the QRS complex. Oh, sorry. No, this one. This one is sorry. This I labeled the wrong QRS beat. This one is during the ablation site. You see that there is a pre-excitation here in this ECG, and in this ECG there is no pre-excitation, which means that the accessory pathway have already been eliminated. This one here, there is a potential pathway here, and the signals from the QRS complex is quite faster than the signal from the distal ablation is faster than the QRS complex. And we ablate this patient, and after that you see that there is atrial signal here, and there is His here and V here. So the His is not negative or do not come after the V. So in this patient, the accessory pathway has been eliminated. There, the different side of the accessory pathway give the the, uh, the different success rate in the different side, because there are a lot of factors that could affect the catheter movable to the side of accessory pathway. The right side of the accessory pathway is the most common recurrent or the most failure ablation site, because the right side accessory pathway and uh, is in the location that the catheter cannot be moved to, or it's difficult to move to that location. The reason for failure to ablate a right side accessory pathway is the first one is the inability to localize the pathway, because you could not find the right spot to ablate, because it is quite difficult to maintain the catheter in those directions. So when it is difficult to maintain the catheter in those directions, the contact is poor and it is inadequate heating to the tissue. So the right side accessory pathway might recurrent after the ablation. In the right table, that there is a factor that could result in the probability of success rate of right side accessory pathway. You could see that the success rate is quite variable between each factor. So for this page, I just want to tell you that the right side accessory pathway is harder to eliminate than the left side. So sometimes we have to use a technique to okay, if the accessory pathway is in the left side, surely it is in the left ventricle. There is two methods to reach the left ventricle. The right picture is called the retrograde atrial approach, because it is in the left side. The accessory pathway is connect between the left atrium to the left ventricle. So we have to reach it from the left ventricle. we have to puncture into the right femoral artery through the aorta and use the catheter to goes into the LV and LA. This is called the retrograde aortic approach. Or we could put the catheter into the right side and we puncture the septum of atrium and put the ablation catheter through the septum into the LA and LV. This is called transeptal approach. We could do both in the left side accessory pathway. The transeptal approach needs no arterial access and easier to control the catheter. But the energy to the heating was more difficult to achieve. There is some risk of perforation and air embolism during the transeptal approach, and during the transeptal technique, we have to use the intracardiac echo, or we have to use the transesophageal echo during the transeptal puncture. So it might be costly than the other type. The retrograde aortic approach, you have to puncture the artery, you have to go up into the aorta. So there is a risk of aortic injury. And also, you approach from the left ventricle, which there is a coronary artery ostium around that area. This could result in an injury of the coronary artery system. This one is more difficult to move the catheter inside the ventricle, but when it reaches the position that we want, it is stable and it could generate more heat. This is the complication of ablation of accessory pathway. There's some mortality around 0.02%. 3% have serious complications such as cardiac tamponade, AV block, coronary spasm. And if you use the retrograde aortic approach, you have to puncture the femoral artery. There is some complication related to the femoral artery puncture, such as large hematoma or bleeding in the abdomen. There's a risk of transient neurological deficit around 0.1%, which is a stroke or TIA. And the outcome of the ablation is around 98%, which is higher than the AVRT. So this has the success rate is much higher than the complication rate. The ablation is the first line of treatment in patients with accessory pathway. So this is all of the lecture here. Anyone has any question about this? I think it is quite new for you about these manuals. Do you have any books or any quiz about this before you have any textbook about the EGM or the manual?
ไม่มีครับอาจารย์
ไม่มีเลยเหรออ๋อเดี๋ยวผมฝากอาจารย์สุภาดีไปให้ก็ได้เดี๋ยวจะฝากอาจารย์เขาไปให้นะเดี๋ยวเป็นหนังสือแบบง่ายๆของแมนนูเวอร์
ได้ครับ
โอเคถ้าไม่มีคำถามแล้วก็มีใครจะถามอะไรอีกไหมครับ น่าจะมึนกันอยู่มันยากค่อนข้างยากยากมากเลยด้วย ถ้าตอนนี้ไม่มีคำถามไม่เป็นไรเดี๋ยวค่อยส่งมาถามทีหลังก็ได้แล้วก็เดี๋ยวผมจะส่ง เดี๋ยวส่งหนังสือไปผ่านทางอาจารย์สุภารดีนะ ก็ขอบคุณมากนะครับ ก็หวังว่าจะได้ให้ความรู้กันไปนะ งั้นก็ขอจบเลคเชอร์ของวันนี้แค่นี้นะครับ
ได้เลยค่ะขอบคุณมากค่ะ
ขอบคุณมาก
ขอบคุณค่ะอาจาร
ขอบ
ย์
คุณมาก
ครับ
Thank you ค่ะอาจารย์